Can you see my slides? Okay. Good day, everyone. You can hear me now? Okay, you can see me. Okay. And I'm just going to share my slides. Thank you. Good day, everyone. It's the third of a series of 3 webinars from the World Association for Infant Mental Health. First one in conjunction with our Australian and UK affiliates and the UK Parent Infant Foundation. But here we are together for the third webinar under exceptional circumstances, of course. The webinar is taking place in the days after what would have been our World Congress person-to-person meeting in Brisbane, but obviously because of the COVID pandemic, that's been postponed. So we're hoping to see everyone who's able to come in Brisbane next year. Meanwhile, we're really privileged to have an amazing panel of presenters to talk to us today about new developments in infant mental health in relation to the COVID crisis, but also key underlying concepts and practices about how we engage with infants and parents. So we're really excited to have the panel join us today, and I'll introduce everyone in a moment. Meanwhile, pardon me, I'd really like to acknowledge that I'm on the lands of the Wurundjeri people of the Kulin Nation, who've been custodians of the land where I'm joining you today for thousands and thousands of years. And I acknowledge and pay my respects to their elders past and present. And I also acknowledge the importance of respect for all communities and peoples of the world, and the importance of caring for our environment, which sustains us all, and the importance again of respect for each of us and our fellow human beings. Thank you again. I'd like to acknowledge the work of my co-organiser for the webinars and on the program side, which is Astrid Berg, Professor Astrid Berg in Cape Town. And I'm so pleased that there we are. Astrid has been able to help bring these webinars together, and I hope we have an enjoyable and productive time today, each of us in our own individual time zones. I guess the key angle that we have today is the notion of seeing the world through the baby's eyes, the baby's perspective. Last week was Infant Mental Health Awareness Week. This week is Awareness of Fathers of Babies Week. I discovered But last week we were focusing on how we see the world through the eyes of babies. Often we don't see the pain, the experience of trauma, fear, sense of abandonment and loss that babies might experience. But often we're missing out on the baby's experience of joy and happiness, playfulness, when we don't see babies as people right from the beginning. We know that babies can be withdrawn, depressed in the context of myriad of traumas that there are that could confront them. And it's our job to listen to infants and toddlers, to see what they see of the world around them. And as we know, the world at the moment is a very stressful and at times confusing place. I've got a few official things to mention, and the first is it's a delight to announce that Professor Astrid Berg, who's been helping us put the webinars together, has been selected as the President-elect of the Weim board. And I really look forward to working with Astrid in the Weim activities. Gus has put the slide on. Does that mean I'm not sharing properly? Let me just check. Can I ask if you can see a slide with a picture of Astrid on it? Just to... Yeah, okay, I'll keep going. Thank you. Thanks, Jody. It's great to get comments from people from time to time, and we've just heard from another of our board members, Jody Manley, who's the past president, executive at large on the board. So greetings from the board, and you'll see on the screen above you Hisako Watanabe, who is a key member of the board of WAIMH, and has managed to join infant mental health organisations in Japan, and is going to be a key person in linking with our colleagues around the world, and in Asia in particular, but everywhere. And Joy Osofsky is past president of WAIMH. I don't know how many pasts I need to put in first, Joy, but Joy's as busy and active and as strong an advocate and a teacher around infant mental health as anyone. Anyway, I'll come to introductions in a moment, and I'll have to be careful not to be too discursive because I haven't got anyone sitting in front of me telling me to slow down. My other task is to not do that. I think I just need to go here. Yeah, is to announce two of the Weim Awards as we're moving into the webinar. The first is the Weim Award, which is given to the awardee in recognition of significant contributions to the World Association for Infant Mental Health, either directly or through one of the Weim affiliate organisations. And it's really my delight and honour to announce that Professor Jane Barlow is the award recipient for this year. Jane Barlow is an extremely powerful force in delivering the objectives of the World Association for Infant Mental Health. Jane's been instrumental in improving programs for the mental health of children and their families in the UK and way beyond. Jane began her career as a nurse in Lincolnshire, and throughout she's demonstrated enduring passion for building research, academic rigour, public advocacy into the foundations of effective health and social services for children and families. Jane is president of the Association for Infant Mental Health UK and Professor of Evidence-Based Intervention and Policy Evaluation at the University of Oxford. As the president of AIM UK, Professor Barlow has vigorously fostered active participation by all members in the activities of the organisation. She's brought together frontline clinicians, researchers, teachers, trainers, policymakers to make a powerful coalition for the welfare of infants. Recognising the importance of early intervention and supporting those working directly with infants and families, Jane advocated strongly for the provision of nurse health visiting when it was under some threat. Her role in the establishment of the Institute of Health Visiting is just one example of her impact and increased government awareness of this and their support for early intervention in the UK. Teaching and training have been at the core of her work. As Pro-Dean of Research at Warwick University, Jane developed an innovative and globally available online training in infant mental health. Jane has been a major contributor to the workings of WAIMH internationally, as affiliate council representative on the board and as associate editor for the Infant Mental Health Journal. She's been an advocate actively for the prevention of violence within families across their lifespan. And as the chair of the local organising committee of the 2014 WAIMH Congress, Jane was instrumental in the overwhelming success of the Edinburgh Congress and has been actively involved in scientific program committees for subsequent congresses. She has, through her extensive academic activities, encouraged research and program development for infants and their families. Professor Jane Barrow, through her commitment to infants and families and the goals of WAIMH, is exceptionally deserving of this Weim Award. So congratulations for Jane and for helping us put the webinars together, as Jodie reminds us. The second official announcement I'd like to make is the, which would have been made in Brisbane, and we're now making it in the virtual mini Congress, if you like, and that is the recipient of the new Investigator Award. And the recipient is Dr. Lars White Phd. Dr. Lars White received his PhD in psychology at the University of Leipzig in Germany in cooperation with the Max Planck Institute of Evolutionary Anthropology. Dr. White holds 2 master's degrees, an MSc in Developmental Neuroscience and Psychopathology from University College London, and an MA in Psychology from the International Psychoanalytic University in Berlin. Dr. White is currently leader of a research group at the Department of Child and Adolescent Psychiatry, Psychotherapy and Psychosomatics at the University of Leipzig. In his work, Dr. White studies the biopsychosocial mechanisms underlying the impact of early childhood relationships and on later outcomes. He examines psychosocial risk, protective factors arising from child maltreatment and peer victimization, to attachment representations and social support. His research goal is to unpack the dysfunctional social cognitive affect, mentalizing, attachment representations, cooperativeness aspects, and neurobiological processes that are thought to lie at the heart of various mental health problems. For example, he's shown that internal attachment-related representations provide the basis for expectations about new encounters with unfamiliar others. Also, with his colleagues, he's developed a model on the neurobiology of attachment disruption disorganization, making innovative proposal that disruptions in early caregiving are associated with distinct neurobiological hyper or hypoarousal phenotypes. This is based on the extent to which caregivers act as threatening or insufficient sources of co-regulation. He's also contributed to theorising about the role of fathers in child psychotherapy, drawing on current knowledge of paternal challenging behaviours, triadic competence, and children's fathers' representations. Dr. White has been able to secure funding for his work and an impressive publication record, which include papers in leading journals such as Developmental Science, Development and Psychopathology, Journal of Child Psychology and Psychiatry, BM Psychiatry, and more, in many of which he's the leading author. Clearly, at this early stage of his career, he's already made and undoubtedly will continue to make important contributions to the fields of developmental psychology, Dr. Lars White. So my congratulations to Jane and Lars, and we look forward to hearing more from each of them in various ways as we go. I mentioned, I'm going to move into the webinar. I just mentioned earlier that last week was Infant Mental Health Awareness Week, and this is just to emphasise the importance of us working together as an international group of people interested in infant mental health, that each of our countries have got unique and particular ways of trying to improve services and lobby. This is an example from the 1001 Days movement in the UK and Parent Infant Foundation, which we shared at our first webinar. This is the second of the webinars, the first WAIMH webinar, which occurred last week, and was chaired by Astrid. And we had our past president, Professor Kaivon Singh Elizabeth Hone, who was chair of the program and local organising committee rather for our Congress in Brisbane, Dr. Dilys Dawes, Professor Miri Keren from Tel Aviv, and Gianpaolo Nicolai from Rome. So today, this is our panel, and it's a real delight to announce that we're going to hear from Professor Kim Mulholland, Dr. Tessa Baradon from the Anna Freud Centre in London, Hisako Watanabe from Tokyo, and Arietta Slade from Connecticut, from Yale, and Professor Joy Osofsky from New Orleans. I'm going to introduce each of the presenters in a little more detail just before they present. So I'm going to move forward to introduce now our first speaker, who's Professor Kim Mulholland. Kim, I've known now for 50 years, since we were in medical school together. And so it's you know, an especially wonderful pleasure to be able to introduce Kim and have him share his experience working with children and families as a paediatrician today. Kim spent about half of his working life outside of Australia, mainly in developing countries, the Gambia, Sudan, India, but also with WHO in Geneva and the London School of Tropical Medicine in the UK. In Melbourne, Kim established the Centre for International Child Health in 2001 and leads the New Vaccines Group at the Murdoch Children's Research Institute here in Melbourne. He focuses mainly through this program on low and middle income countries with projects in Fiji, Vietnam, Mongolia, India and Ethiopia. And his interests are around childhood pneumonia, respiratory diseases, pneumococcal vaccines, and now, of course, COVID-19. So Kim's going to talk to us today about the science and uncertainties of the pandemic, and I'm really looking forward to Kim's presentation. Thank you, Kim.
Thanks, Campbell, and good morning, good afternoon, or good evening, everybody. Can you hear me clearly?
Very clearly.
Thanks, Campbell. Firstly, I'd like to acknowledge the traditional owners on the land from which I'm speaking, the Wurundjeri people of the Kulin Nation, and I support all of Campbell's comments in regard to the traditional people and the Indigenous people of this country. My task today is to speak a little bit about COVID-19 and how it affects children. And I guess you will see as I go through this talk that it affects children in more ways than just the direct infection. My fear is that at the end of the day, when the COVID-19 pandemic is settled and people look at what's actually happened, we'll find that the casualties of the pandemic might be millions of people actually. Many of them will be adults, many of them will be older adults with underlying conditions. But I fear that the cost to the world's children may be greater, and that's what I want to speak about today. For people who are not truly familiar with, and maybe everybody's familiar with this virus by now, but the disease COVID-19 is caused by a virus that's known as SARS-CoV-2. It's a coronavirus, and coronaviruses are basically viruses of animals. And there's a few that have caused mild disease in humans over the years, mostly common colds. And then 3 that have caused increasingly unpleasant epidemics and now pandemic. The first of those was SARS-CoV-1, which caused the epidemic of SARS in about 2002. MERS, the Middle East Respiratory Syndrome, came a number of years later, and that was mostly in the Middle East, and it was a disease originally of camels. And now SARS-CoV-2, or the disease of COVID-19, really appeared late last year, and the first person to recognize this disease was this young doctor, Li Wenyang, who identified a cluster of severe pneumonia cases in his hospital in Wuhan, and attempted to inform all his colleagues, but was reprimanded and punished for that. Sadly, Dr. Li died of the disease in February of this year. Now, the risk to children, there is some risk of infection, but I'm going to speak a little bit more broadly about the overall risk to children. The risk of actual infection for a child who's exposed is probably the same as it is for older age groups. In other words, if a family is exposed by a family member, then the chances of an individual child getting the infection is probably the same as everyone else. But the risk of serious illness is actually very low. The reasons for this are unclear. There are some very detailed hypotheses that people are working on at the moment, and I won't go into that because that's not so important for this talk. Starting though with perinatal issues and having and considering what happens in pregnancy, there have been reports of placental infection and abruptio placentae, which has caused the loss of some pregnancies, but this is actually quite rare. And this goes along with our understanding of the infection, which is that it is not an infection that generally causes viremia. And so it's viremia, of course, which allows the infection to be transmitted to the fetus and through the placenta. In Britain, around 100 women a week have been admitted to hospital with pregnancy and COVID infection. And the first report of the outcome of these admissions was published very recently. And in that report, 5 of 427 women died, which may seem to be rather similar to the general mortality for people admitted with COVID-19. But at the time of the publication, there were 9 women in intensive care. So there probably is an increased risk to pregnant women, but it's not a huge increase in risk. At the time of birth, there is an issue though, and that is that in some hospitals in some parts of the world, the children born to infected mothers have been physically separated from the mother until such time as the baby, and indeed the mother in some settings, can be shown to be negative. Now, this is not good practice, certainly not recommended in this country, Australia, but I believe that there are still some places where this is happening. The general recommendation is for babies to be breastfed as usual. The bigger problem, though, which affects all women who are giving birth during the pandemic, is the almost inevitable lack of support for women around the time of birth. The normal arrangement, of course, is that women are supported by friends, by family, by their partner as they enter labour and during the time of birth and then after the time of birth. And this is true in all communities of the world. We see now, unfortunately, women are delivering in what can be a strange and hostile place with people dressed in strange clothing, and it can be more scary than it would normally be. There's also been an increase in home births. This has been seen in Western countries, but also in places like India. And I think the Indian authorities believe that this will directly translate into an increase in neonatal mortality and possibly maternal mortality. Neonatal infections have occurred, but there are small numbers. Some of them have been serious and there have been some deaths, but it's really only a tiny number given the total number of infections. The virus has been reported in breast milk, but that's only 1 or 2 reports, and I think that's work that's still underway. But just to highlight the pattern of serious coronavirus in children, this relatively small series of 48 children represents children admitted to intensive care units in Canada and the US. And you can see, firstly, the relatively small number of cases. Secondly, about half these cases are teenagers, actually, and most of these are children with underlying conditions. So it's unpleasant for those children concerned, but this is not, from a public health point of view, a very large issue. There is this condition which has the extraordinary and impossible name of Pediatric Inflammatory Multisystem Syndrome temporally associated with SARS-CoV-2 virus. It's a condition that's a little bit like Kawasaki disease. In fact, it's quite a lot like Kawasaki disease, although the children are older and toxic shock is more common. It's potentially serious and potentially a fatal condition, largely because of the cardiac effects. But again, to give you an idea of how rare this is, we've not seen a case, a straightforward case of this condition in Australia. One potential case has been investigated. A bigger problem, though, is seen by this slide, and this is data from Italy, where during the peak of the epidemic in Italy, there was a dramatic reduction in visits to paediatric emergency departments in various cities in Italy that are described here. And that reduction in visits belies a reluctance of people to attend the hospital. And in this particular paper, they described a number of very serious consequences of that, including a delayed presentation of diabetic ketoacidosis, which had serious consequences for the child concerned. So delayed access to healthcare is an issue everywhere. But I've been mostly concerned with what's going to happen in the poorer countries of the world. And to a certain extent, until a few weeks ago, there was a feeling that maybe for some reason these countries may escape the worst of this pandemic. And then this appeared from Mumbai, and this is about 4 weeks ago, and it started to become clear that Mumbai really had a major problem with the virus, and at that time represented about half of the cases in India. It's since spread to the other major cities of India, and this recent report from an Indian newspaper describes a large population of people who live in the big cities of India who are itinerant workers. These are people who come mostly from the poor rural areas of India and come to the big cities to work in often day labouring jobs, often sleeping at their place of work. So in a lockdown situation, what could these people do? It was extraordinarily difficult. And the government responded by arranging special trains to take them back to their villages, which may have seemed a reasonable idea, but unfortunately has probably spread the virus now throughout India, and we're now seeing signs that India has a very major problem with the virus. In Africa, I've seen a number of reports from smaller and poorer African countries showing only a handful of cases, and mostly occurring amongst the elite, interestingly, because of course these are the people who travel internationally, and many of those cases have come from France or from other parts of Europe. Then this came from Nigeria. Kano is one of Nigeria's, well, Nigeria's second biggest city. And this report describes an overwhelming problem that the Nigerian authorities hadn't really spelled out very clearly. And personal reports that I've had from Nigerian doctors indicate that there have been quite a few doctors have died in Kano, including 2 professors. And this at least indicates that there is a substantial problem in northern Nigeria. But the bigger issues for children and, associated with COVID-19 are not related to the virus directly. It's related to poverty, malnutrition, the reduction in healthcare I've already mentioned, but we should also remember the importance of preventive healthcare, which I'll come to, particularly immunization and malaria control. Then the psychological stress and trauma that is inflicted on families and individuals due to government policies, which have been quite cruel in some countries, associated domestic violence and disrupted education. For example, in Mongolia, which actually is probably the country in the world that has been most successful at preventing this virus, controlling it and preventing it really from entering the country. And they've had no actual community-controlled cases in Mongolia. But schools closed in January, and they will reopen, I'm told, in September. So that's for 9 months. Schools have been closed in that city. The economic issues have been highlighted by this recent report from the World Bank. And what this figure shows is, by region, an estimate of the number of people who've been plunged into poverty as a direct result of the pandemic. And you can see that the numbers there add up to around 200 million people, and most of those people are in South Asia and Sub-Saharan Africa, as you might expect. So poverty doesn't come without consequences, especially for children. And the city in Africa which has seen the most cases of COVID-19 is, well, the country is South Africa. I'm not sure. I think Cape Town actually has seen more cases, but this picture is from outside Cape Town, yes. But it's still not a very large number of cases by comparison to what's happened in Europe. But this information that I got just recently from a group working in South Africa, doing research into the effect of COVID-19, included an examination of the effect on children. And so in Baragwanath Hospital, which is well, I think it's the largest hospital in the world, they are conducting a study which involves the enrolment of anybody who really could have COVID-19 infection. And that includes all children with severe pneumonia. And at the time when Dr. Shabir Mahdi was presenting this information on a WHO meeting, they had enrolled 400 children with severe pneumonia in this investigation, and not a single one had tested positive. And I think this gives us a little bit of an indication of the relatively low probability of severe infection in children. But the real problem is coming from things like this. And this is a map of the world showing the countries that have had severe or extreme total disruption of immunization services as a result of the pandemic. And those countries are shown in red. It's extraordinary, and most countries have had some effect, but quite a number of countries have completely stopped all immunization programs. Now, the World Health Organization estimates that the children who are born this year, about 2/3 of those children will be born into countries where there has been a severe disruption of immunization services. That disruption means not only the routine immunisation, but it also is the disruption of campaigns. And for the control, particularly of measles and polio, that's a major issue. In fact, the WHO currently estimates that 173 million children will have missed out on measles vaccine as a result of this pandemic. And some estimates have then been made to say, well, where will this place us in terms of measles coverage around the world? Well, it may place us in a situation a little bit similar to 1980. And in 1980, it was estimated that 2.6 million children died of measles that year. I want to emphasize that children dying of measles is complex. Some children die in the acute phase of the illness, and some children die during the months following the illness because of the immune suppression, chronic malnutrition, and the other things which follow on from measles. It's a devastating illness, especially for communities like this. And this was 1980 in Sudan, when this was the first time that I personally had to deal with the problem of severe measles and fatal measles, and it really was horrifying. Because the children who die from measles are quite often children who have marginal nutrition to start with. Measles plunges them into a state of malnutrition, and what follows is really a rather unpleasant course of events. And one of the most common consequences then in that situation, and indeed in other parts of the developing world, was the disease known as kwashiorkor. Now, kwashiorkor is a form of malnutrition when children become quite edematous. The child you can see in the picture on the left here shows some very typical features of kwashiorkor with edema around the feet. And he also is marasmic. But the striking thing about this child, and this is a really striking thing about this condition in general, is this sad, detached and depressed appearance. And this was described by Dr. Cicely Williams, who's seen in the photograph to the right, who was the first to describe kwashiorkor in Uganda. And she described this as, in fact, the name I think was taken from a local language, and it means the disease of the deposed child. And typically seen in non-famine situations when a child is abruptly stopped from breastfeeding when the mother becomes pregnant again. And that was the kind of scenario that Dr. Williams was describing when she first described kwashiorkor way back. Another famous description of kwashiorkor comes from my first pediatric boss. Dr. Janet Goodall was the consultant that I worked for in Stoke-on-Trent in the UK in the late 70s. And she wrote this rather famous paper about malnutrition and particularly kwashiorkor. And Janet described, based on her years of work in Uganda, described kwashiorkor as a form of childhood depression. She said, and I can say this from personal experience, it's true. It's very hard to manage these children because they will not eat. It's not just starvation, it's withdrawal from life almost, and it's a terribly desperate condition. And so I'm not going to say more about this, but I want to just make the general point then that the casualties of the pandemic are going to be many, and most of them will be people of my age. But the cost to the world's children, I believe, will be greater. And I hate to think that we're going to go back to the levels of malnutrition, poverty, and measles that were seen in the 1980s, but I fear that this is going to happen. So on that depressing note, I'll stop, but thank you for your attention.
Thank you very much, Kim. That's very informative, salutary, but very helpful too. I think the comments you made at the end about the integration of the physical health of the child and the emotional health of the child are really very crucial for us, but also the challenge of how to reach large numbers of people in a way that might support infants and toddlers get through the crises that lie ahead. If you can click off your share screen, Kim.
I've actually done that, I think.
Okay, all good. All good, thanks a lot. Because I'm going to introduce Dr. Tessa Baradon from the Anna Freud Centre in London. I've known Tessa for a long time as well, but not 50 years as I've known Kim. But it's been a delight to be able to go for episodes of Renutrition to the Anna Freud Centre in London, and other colleagues there at the Tavistock, but particularly at the Anna Freud Centre, where there's a special interest in infant parent psychotherapy. And Tessa's going to talk to us about infant parent psychotherapy by telehealth. And I'm wondering for all of us to think about ways that we can adapt our techniques of working with infants and families to maybe reach more and more families. Tessa is an infant mental health consultant and head of training in psychoanalytic parent-infant psychotherapy at the Anna Freud Centre, with research interests in cross-cultural learning about parent-infant relationships and the clinical process in therapy. She's also published a number of books, edited, and her own papers around infant-parent psychotherapy. The Anna Freud Centre also produced a very useful set of guidelines right at the beginning of the pandemic on work with infants and families in psychotherapy. So I'll hand over to Tessa. Thank you so much. Are you able to click on? Yeah. I can hear you, yeah, all good.
Okay, thank you very much. It's an honor to be invited and to follow such a very moving presentation as given by the previous speaker. Even though speaking in epidemiologic terms, it felt very personal to each child, to each baby. I'm going to speak first and foremost as a clinician, and as a clinician who had to move very rapidly from face-to-face contact with patients to remote working. And what intrigued me was how we are suddenly faced with a tension between the medium of remote provision and the human need for closeness and in such a period of heightened societal and personal stress. So I'm going to consider some of the unique issues that can arise when working with babies and their families, particularly via the video platform. And my focus is on the central question of how to create and sustain a safe space for therapy in the digital frame. And I'll suggest that changing the physical frame of therapy through working online potentially affects its boundaries, textures, internal and interactive rhythms, and that consequently we need to modify some of our thinking when working in this way. So I just want to say a few words about changes to the physical frame. Some therapists were already working from a private consulting room and didn't experience the physical dislocation when the lockdown was started. But those who normally work from an organizational base lost the safety of that familiar environment. And that, of course, doesn't only apply to therapists. I supervise numerous therapists, especially those with young families, who do not have a closed and distraction-free area in their homes that can replicate the boundaries of a consulting room, characterized by constancy and privacy, both for the patients and for them. As one younger therapist said, "My baby can hear my motherese cadences, but they're not directed to her. How can she make sense of that? And what does this therapist's patients hear," he worried, when his own infant was having a meltdown. 2 babies in his care. Another aspect of working from home without adequate preparation is that the inequalities between therapists and patients can become evident, and the fantasy of the therapist's riches is no longer held within the transference relationship. And this can be very uncomfortable and guilt-provoking for the therapist. So tricky personal and professional dilemmas may arise, like how much curiosity from the other is tolerable, and what can safely be discussed, and is this within the remit of parent-infant work? For example, on one occasion early on, I struggled with technology and could not blur the background in my office. And the father immediately noticed that and said in quite an excited way, "We can see your room." And I really didn't know what he was thinking about that, but I certainly felt as though some sort of propriety had been breached. And I wondered how his wife felt hearing him. So should I have taken that up? And was I to blur or not to blur in the following session? In a similar vein, while some patients have a lot of experience using video, for example, to keep in contact with distant family, for others allowing a professional and her or his camera into their home can be really challenging. How they experience our gaze at any moment will probably hold their internal world in relation to the external world, in fact, their internal working models. There are other explanations as well. For example, Fonagy and colleagues suggest that the extent to which a parent has developed epistemic trust, the trust in the authenticity and the personal relevance of knowledge conveyed by another, in this case, the therapist, will impact their ability to adapt to the video therapy, to the change, in fact. Those who established epistemic trust more successfully as children are more likely to adapt to a changed external reality and to continue to connect to a therapist even when divided by a screen. In contrast, they suggest that where epistemic trust is low, the change can be experienced as a rupture that heightens vigilance, suspicion, and reduces flexibility. But we must also remember reality in all of this, in that both patients and therapists are responding to a very real situation of danger in the outside world. My next thought concerns the question of how the therapeutic space may be experienced. with the more or less abrupt advent of online contact, I think we lost our roadmaps of how sessions go. We were faced with uncertainty as to how to weave the interpersonal field between us online. For example, suddenly we arrive on each other's screens without a physical journey towards a meeting place. We settle into being with the other at a different rhythm. There's no placing of bags and coats and moving to the floor and fashioning a sense of togetherness in the physical room around us. The first thing I noticed was the limited range of embodied vocabulary, and I still acutely feel the loss of a rich language of gesture and orientation and of breathing, shuffling into a comfortable position. Gaze is amplified, but the field of vision is limited by the camera. And this creates a different way of being and a different rhythm. In my view, one more reliant on words and on conscious thought, and less facilitating of reverie and of silences. And there's also more room for misunderstanding because of insufficient access to the body cues that tell us how what one has said has landed with the other. Babies also have different reactions and struggles with this new way of being with a therapist and parent together. Those who have had a prior face-to-face contact with a therapist may be curious, and I quote here one of our trainees who said that, "I have had one baby pick up the phone and inspect the back of it. I wondered with her mother what she might be doing. Mother understood this to be her baby's attempt to find me physically in the phone. We then shared thoughts about what might be going on in the baby's mind. For example, why is therapist now small and flat? And can you come out of the phone if I shake it?" She compared this to another baby she sees who showed increased jealousy and a feeling of exclusion when her mother was talking to her on Zoom, whereas before in their face-to-face sessions, the baby did not display such distress or attempt to fight for the mother's attention in the room. And the therapist wondered if the baby had an ingrained association of mother being on the phone equals losing mother and her attention. Other therapists have emphasized how you can work more easily with toddlers and play with them. But my impression is that even with toddlers, digital working complicates our ability to create a direct therapeutic relationship with the baby in the moment. And when we think of the body of work of the microanalytic researchers who've demonstrated both the minuteness and the rapidity of embodied expression, we can understand, I think, how the screen can blunt this so that synchrony can be more easily compromised. But there can be an advantage in this situation in that we might be working more with building the parents' mentalizing capacities, in that we are so reliant on the parent to observe and describe the baby, whereas we had direct access to the baby before. And in this way, the parent can become the therapist's camera and an extension of her mind in relation to the baby. And of course, then there is the discussion, as I described earlier, with the therapist wondering with the mother about the baby seeking her. So what adaptations of technique have come about? We have found that it is important to stay with the here and now of our patients' daily lives and give opportunity to mentalize current frightening experience, which may flood already over-aroused parents and babies. We think that more thought has had to be given to exploration of past trauma in this situation, and we suggest refraining from interventions that arouse anxiety and can challenge our patients' coping mechanisms. In tandem, within each session, we need to think with the parents not only about their upsets and fears, but also about how they rally themselves within each session. For example, a parent describes being driven mad by a situation. It's not sufficient to explore why and how they got into those states, the triggers to the stress response, but also how they got out of that state of mind, their more resilient aspects of functioning, so that when the session ends, they can step back from the conversation with us into locked down parenting. I've also heard therapists devising such creative ways to help mothers, fathers, and babies. An example from a colleague working in an intensive neonatal unit in Chile, and I quote her, "Parents' visits are still suspended and our access as psychologists has been restricted. So our interventions have had to be adapted to this new setting. We have been implementing an intervention that uses technology to bring babies and their families together. We ask parents to send an audio message with words, songs, poems, or whatever is most spontaneous for them to send their baby. Then we take this, we approach the baby, explain why their parents are not there, and present the parents' audio to the baby and video the baby's reaction in response, and then pass the baby's reaction on to the parents, thus trying to give continuity to the vocal, auditory, emotional experience from the womb. And finally, I will end with something I learned from the baby patients I'm working with online, and that these babies sometimes move out of range, or the camera falls, and I am left with changes, with a baby who's physically absent from the screen or appears in bits and pieces, just a close-up face or even just an eye or a hand. And I have an experience of their world, I think, the world through the baby's eye, in miniature, often unintegrated, unpredictable, not making sense, arbitrarily disconnecting us. And I try to use this imagined experience with their parents and with the baby in linking internal and online worlds, so as to reinforce the primary tasks of such therapy, to create emotional connection, integration, and meaning between us. Thanks.
Thank you very much, Tessa. That was brilliant and extremely helpful. I really like the last point in particular about the screen giving us an opportunity to see the baby's world from their point of view. It's quite powerful that way. And I should add that you've been doing, you mentioned colleagues in Chile, you've been doing a lot of work in Johannesburg, working with the Uber Bailey group, and adapting parent-infant psychotherapy to work in really very challenging circumstances. So you've given us a lot of food for thought, how we can use technology in our sort of more regular day-to-day work, but how to adapt it and reach beyond and greater numbers. Thank you very much for your talk, and we look forward to some discussion at the end. Again, if people have got some questions that they want to put to the panelists, if you go down to the bottom of the screen, there's a little Q&A logo there. You can type in some questions as we go. It's my great pleasure now to introduce our next presenter. If I can share my screen. Who's Dr. Hisako Watanabe from Tokyo. Hisako is a friend I've known for many years as well. Hisako is one of the most industrious people I know in terms of working with trainees, with families, with colleagues. She's a child psychiatrist in Japan, in Tokyo, who's integrated Western transdisciplinary neurobiological psychodynamic approaches with Japanese concepts such as that of amai. She graduated from the Keio University School of Medicine in Japan and trained in pediatrics, psychiatry and neurology. Hisako participated in many WAIMH activities since 1986, it's a long time, and has trained at the Tavistock Clinic. She hosted the 11th World Congress for WAIMH in Yokohama in 2011, and that was a magnificent event. She pursued manifold practices and research, including research on the establishment of comprehensive system of treatment for teenagers with anorexia nervosa, and investigating communication in premature babies, particularly using communicative musicality, which she'll talk to us today. She had Japanese government funding to do this work. She also founded a national forum for study of infant and neonatal development in Japan, conducted post-disaster care after the 2011 Great East Japan earthquake, and now supervising cases around Japan. She works in the Watanabe Clinic in Yokohama with a husband who runs a community and family-based practice. She's recently outreached and visited Bangladesh, and which opened her eyes to the richness of intuitive parenting in Indigenous communities. She maintains that WAIMH has a crucial role in this pandemic to respond to the diverse needs of infants and families around the world. And Hisako is very well placed to lead us in that. And we look forward to your talk, Hisako, helping your baby and young children with joyful companionship, clinical application of communicative musicality. Hisako, thank you very much.
Now, hi everybody. As introduced, I'm a child psychiatrist from Japan, working in Yokohama. And today I'm going to talk on the title of Helping Babies and Young Children with Joyful Companionship. Subtitle is Clinical Application of Communicative Musicality. Well, at this humanitarian crisis of COVID-19 pandemic, we daily exercise affection and cautions, which are part of our human sense. And being confined at home, we are led to reflect on the basics of life and to the reality that we are all equal as we start from a tiny cell carried in our mother's womb. From the beginning, each of us is a person in his or her own right, at one with nature, the mother womb. And in Japan, babies are very carefully nurtured. They sleep with mothers and they sleep with parents. And they're taken into the field to be near the parents for proximity and protection. So, as my patient who recovered from anorexia and became an artist and poet wrote, we are aware that very much in us is that unconscious memory of infancy, of being embraced in the family intimacy, like a fetus in the womb. So amai derives from word amai, meaning sweet. But in the context of COVID-19, I would like to highlight amai, which entails cautions to maintain safety inside. For example, Japanese people put on masks. Japanese people bow, not hug or shake hands. We wash hands and bodies very, very cleanly, and we take off our shoes when going into the house. So, social distancing in Japan has been part of our cultural affections and cautions. But communicative musicality is a simultaneous vocal, visual, and kinesthetic expressions developed phylogenetically in interaction between ancestral mothers and infants. Well, it's the origins of the capacities later used by humans in making and responding to music. We Japanese are also very, very in touch with closeness and distance, and we have invisible border control of inside house and outside house. And I was very concerned about the way the outside world, the government, forces parents to be strict to the children, not to play outside or not to sort of mingle with each other. I was so concerned. And in April, I had a card from Colin Trevathan, our mentors for a long time. And he told me, he wrote to me saying, affections and cautions are human nature, shared in all its adaptive and creative forms. We are born expecting relations of kindness and fun in close and trusted community. So we should, mobilize more kindness and fun for infants and children, and we must be very responsible to keep them joyful. Well, 20 years ago, Colin came as lecturers to our Four Winds Infant Mental Health Congress in Yamanashi, and he also went to Nagasaki, and he also came to Tokyo. He taught us contingency, syngorhythmia, companionship, and all those, very joyful and wonderful elements of intersubjectivity in infancy. Well, in that visit in 2000, when he came to Keio University, I was in trouble with a mother who had a baby named Mio. The mother says, my baby won't open her eyes. She rejects me. And I was at my wit's end and asked Colvin, who came with Nikki Powers, his assistant, and they greeted baby with intimate musical vitality. Well, Mio was born premature and with 18 trisomy. Her mother was devastated to the point of mental breakdown. With crisis intervention, she gradually recovered and came to see Mio in neonatal intensive care unit. Mio was already in cot, out of incubator. Mio kept her eyes closed whenever mother came. Mother said in despair, Mio won't open her eyes. She rejects me. Nobody could solve this. We asked Colin for help. He said, but I'm not a clinician. But with big smiles, he came into the NICU. Well, Colin stood at Mio's feet. He took out a camera and told Nikki to start. And Nikki greeted Mio in a lovely singing tone of voice. Hello, darling. And do you know what happened next? Lo and behold, Mio opened her eyes as if to say, is someone calling me? Then Nikki went further. Hello, darling. What a beautiful baby. And Mio opened her eyes wider, as if to say, do you really mean it's me? Mother standing beside Mio observed this. She was surprised. Mio has responded, wow, Mio, you can understand. Well, she spontaneously picks up Mio in lively, intuitive parenting with a happy voice. And with this happy voice, Mio felt she has found her mother again. And look at this long, long gaze, mutual gaze. They were meeting each other in the moment. And so Mio and mother lived happily until Mio, who has a short life from 18 trisomy, died at the age of 7. But this intervention by Colin really opened my eyes that we must study more about the intersubjectivity of the baby. And we must become a natural scientist in the field of infant mental health. So when in 2004, Colin invited us to join his pre-NAV research international group, we, of course, participated. This pre-NAV, well, is a network on emotional vocalization and expression in proto-conversation before birth. And Colin wanted to prove to the world that infants are born with communicative musicality. So it's embedded in human intrinsic motives. Communicative musicality has contingencies in rhythmia and companionship. And in the research, we're going to measure pulse quality and narrative through visual audio recording analysis. So we have subjects and method, and we set up the machine like this, and you will see a mother talking to the baby who was born premature at the gestational age of 32. And the baby responds to the mother because the mother is happy. 2 weeks before that, mother was tense. The baby did not respond. So just listen to how the mother talks to the baby. It's in the microphone, the baby. Well, you could hear true vocalization from the premature baby. Once again, the baby comes in here and here. No, the baby perceives musicality in the mother's voice, which conveys her satisfaction, happiness, and relaxation. And in spite of the fact it is premature and has difficulty vocalizing, it is responding like this. And they come in tandem and in duet. But if you want to read more about this, here are the books, one original one and one in Japanese. And the authors are from New Zealand, Colin, and Stephen Murdoch from Sydney. Well, going back to Neo's case, I could put the episode into introduction, development, climax, and resolution, and how it builds up into climax, and how the subtle change, the opening of eyes in Mio, facilitated mothers to retrieve her intuitive parenting, which she lost from the devastation of knowing that she has trisomy. What I thought in anywhere in the clinical field, whether it's refugee camp or in Japan or India or Bangladesh or Europe, we can find it with our inner audio-visual recorder and analytic sort of tools. We don't need actual research places. So when I was happy and very fortunate enough to be invited to join the people in Bangladesh who were helping, impoverished areas and so on, I encountered this beautiful interaction. Just listen to the tone, lively, rhythmical, melodious, full of joy. And the children suffer from poverty. And in the Rohingya camp, the children suffered from persecutions and are living under fear yet. When there is an adult who is ready to share the joy of living in communicative musicality, they are ready to respond. Well, here's another example from Great East Japan earthquake and tsunami. In this slide, you can see here the book, Supporting Vulnerable Babies and Young Children. The authors and editors are from Australia, but I was happy enough to have the opportunity to contribute a chapter in which, well, I wrote about the babies in post-disaster areas. Babies and young children in evacuation centers were silently waiting for intimate musical vitality. Mothers were not able to provide. So there was room for us to come in, and our friendly approach elicited joy and laughter. And then the power of children in reviving vitality affect in adults and community was surprising. Well, lastly, I will show a glimpse of how my colleague, Kanai Narui, conducted a group communicative musicality-based program. Well, she, as a clinician in the field, was not aware that what she was doing matched the theory of communicative musicality. So, it is not something written in the papers or studied in universities or laboratories. Communicative musicality is inside us, and we must get in touch with our communicative musicality in order to work well. So with affections from afar, but together in enjoyment of life, this is my presentation, and thank you very much for giving me the opportunity, and thank you, Astrid and Campbell, for organizing this wonderful webinar. Thank you.
Thank you very much, Hisako. That was very powerful and moving, and again shows the capacity that you have for building on the important and ordinary interactions that happen between infants and families, the impact of culture, the context of it all, and how we can do what sometimes seem simple things that are really very powerful with a strong neurobiological basis to it as well. Thank you very much. And we'll have a chance for some discussion later on. And again, don't forget to put questions in the question and answer box for those in the broader audience. Thank you again, Hisako. It's my honour next to introduce Professor Arietta Slade, who is from Connecticut, moving between Connecticut and New York and other places beyond. But Arietta is a professor of clinical child psychology at the Yale Child Study Center. She's a clinician, theoretician, researcher, teacher, co-founding director of the training of Minding the Baby training, which is an interdisciplinary reflective home visiting program for high-risk mothers, infants and their families out of the Yale Study Center and the School of Nursing. This is quite a powerful intervention that's been developed, researched and implemented in a number of centers. But Dr. Slade is an amazing author and has a way of using language to really help us see ourselves and others very powerfully. She authored with Jeremy Holmes the book Attachment in the Therapeutic Practice, which is available through Sage Publications. And she edited a major work on attachment with Jeremy Holmes in 2014 as well. Mind-to-Mind, Infant Research, Neuroscience and Psychoanalysis with other authors, including Jurist, Bergner and others. And a book I really like is Children at Play, which Arietta published through Oxford University Press in 1994. There's so little, I think, that we really have about play, young children and infants. She's currently writing a book on reflective parenting and been in private practice for nearly 40 years, working with individuals of all ages. And I know a very powerful mentor and guide for so many clinicians and researchers over the years. Arieta is going to talk to us today on the preconditions for reflection in dangerous times. Thank you, Arieta.
Hello. Thank you, Campbell. Can you hear me? Okay.
I can hear you. Very good.
Great. Okay. I'm unmuted, and now I'm going to share my screen, God willing. Oh, my goodness. Miracle.
Great.
Okay.
Thanks a lot.
Thank you. It's my really, really great pleasure to be here, and particularly to be on a panel with, you know, some of my heroes and people that have influenced me greatly, and also such wonderful compatriots in this journey that we're all on. And especially thank you to Campbell and Astrid for making this happen, and to Gus Fraser McKenzie. He has a new, never mind, that's a long story. But anyway, thank you to everybody. I'm going to talk from the perspective of reaching babies through parents. And, you know, we've spent a lot of time today and in the field talking about babies, but, you know, my work, as many of you may know, has really been about how to work with parents as a means of reaching the baby. And I'm going to talk, you know, first, obviously, about, I'm speaking from the perspective of the US context, which, you know, when I think about some of the contexts we've heard about today from Kim Mulholland, those are even vastly more complicated and more frightening and difficult than the ones we're facing here. But we've obviously had the COVID pandemic, which has had a great impact on the United States with, you know, 119,000 dead and well over 2 million infected. And we've had particularly high rates of illness and death in under-resourced communities. That is, the communities in which people who are living way below the poverty line, who are Black and Brown, are vastly more affected, both in getting, because there's so much viral load, because people are living so close together, many more people have it, and they tend to be sicker from it because of their own histories of their health care inequities and not receiving proper health care over the course of their lifetimes. And of course, they've been exposed, as we know, to great adversity and toxic stress, and this makes them much more vulnerable to an illness like COVID-19. And one of the follow-ups, obviously, one of the things that have been wrought by this illness is economic devastation at a profound level. And you see this particularly within communities where people are already struggling with great levels of poverty. And there's been breakdown of social networks, obviously, because people can't get to their families, they can't get their kids to school, and they don't have places to leave their children. And there was some effort, within the major cities to create childcare settings for essential workers, which was, of course, a wonderful movement. But in general, within these communities that are the communities certainly we work with in our various programs, and that I think many of you work with in the US, there've really been a number of breakdowns. And then, following on this major crisis across the US, there has been the eruption of the simply the Black Lives Matter movement, which has been a movement that's been ongoing in the US for some time, but the filmed police murders of unarmed Black men and women at a time when everybody was already in crisis just has galvanized the country. So we are really dealing with two, and I'm sure you have to, I'm not going to get into politics, but I think clearly that played a big role. But communities that were already devastated have erupted in rage and grief and pain. And so there have been compound losses and compound traumas on top of what was already a pretty devastating, awful situation. And neither one of these situations is anywhere near resolved. They are still ongoing and probably will be. Certainly the Black Lives Matter movement and many of the affiliated political movements, I think, are going to last for a long time, but the infection may well be around, as we all know, for quite a while. So I'm going to be speaking from the position of somebody who's been working on an intensive interdisciplinary home visiting for a long time from a mentalizing or reflective position. You know, our work is really focused on the idea that in order for parents to develop positive, productive relationships with their children, they need to be able to know their children and to hear them and to understand them and to be curious about them, all of which is part of any kind of reflective approach. And out of this work and our work, you know, supervising in the United States and supervising in other countries, and obviously my own work in this field for a long time, developed a model to conceptualize the work we're doing that builds on affective neuroscience, attachment, mentalization, and trauma theories, as I hope you'll see. And it's a model for understanding kind of what we face in our work, particularly in a time of crisis. I mean, this model is applicable to non-crisis as well, but what kinds of struggles we're facing. Oh, I forgot to turn on my timer. Well, I didn't. All right. And so it's a model for understanding what we're facing, and it's a model for where we start in our work when basic safety is threatened, which is a state I think so many of the families we're working with are, and what we hope to achieve with the families we see in these deeply frightening times. So I'm going to start with the model itself, and I'm going to start at the top. And this is really a learning experience, I think, that I've had over the years, which is we started by really reflective functioning, which, you know, is a very important parental capacity. It's manifest in children and their openness and willingness to learn and willingness to explore and their own curiosity. But what we're after in parents is their capacity to be interested in the internal experience of the child. And what we found in training over the years, you know, we've been training people in this model for a number of years, is that when people clinicians started with worrying about whether the mother was reflective or not, they would get derailed. And it was the wrong question. And they started worrying too much about the outcome instead of how you get there. And so we began focusing on what are the foundations of reflection. And obviously one of the first goals, one of the first foundations of reflection, which has been in the literature for 50 or 60 or 100 years, is that the relationship with the parent is what supports the baby's capacity to look out into the world. And it's the relationship with the child that allows the parent to be reflective. And one of the things that we do is we establish relationships with families so that the parents can become reflective as a function of what we provide in the relationship. But the relationship depends on the parent feeling safe and the parent being regulated. And so often I believe we start at the top when really what we actually do is we concern ourselves with safety and regulation. And actually this may be quite evident to many of you that that's where we need to start, because you probably are forced to start there by virtue of struggling that you can't get to the top. So you start where you need to start. And I guess I'm just validating the need to start there. But we're building toward reflection. That is, we're building toward the capacity to explore. But first we have to establish safety and regulation. So let's start with safety. And this was one of Bowlby's, core ideas, was the idea that when the child feels threatened, they turn to the mother. And threat and the activation of the fear system is an absolutely normal part of development. And we are designed to detect threat. And when we feel threatened, we communicate that we are threatened. And when we feel threatened, we're dysregulated, and we rely on primitive defenses. We turn to fight, flight, or freezing. The HPA axis is activated. Our stress hormones, are circulating, not necessarily highly, but they get very disrupted. And that's what's happened when safety is threatened. And when safety is achieved, that is, when the child achieves contact with the parent, or when the child is reassured, or the child is comforted, or the adult is comforted by us and finds solace in us, then safety is achieved and regulation is possible. So that we're striving first in our work with parents and babies to establish safety and regulation, which paves the way toward the attachment relationship. So think of the mother and our relationship with the parents. So think of the mother and baby. The mother provides safety and regulation, and then she's ready to love and connect. And this is what builds the relationship with the baby, is her openness to love and connection, right? If the baby, however, feels threatened and dysregulated, the relationship will be distorted to the great detriment of the child. So it's the parent's capacity to provide safety that really makes the relationship develop. So when we put this in clinical terms, clinicians working with highly stressed families first have to establish their own safety. Are you feeling safe where you're working? Are you feeling safe in your supervision? Are you feeling safe in your discipline? Are you feeling overwhelmed with feelings? Are you safe? Are you dysregulated? And oftentimes that has to be addressed before we can really move into contact with the family. Because unless we feel safe and regulated, we're not going to be open to developing the relationship we need to with the families. And I think in this time of such crisis, we see great variability even within clinicians in terms of their ability to feel safe enough, to feel regulated enough in this very dysregulating time to open themselves to relationships with the families. But once we feel safe, then we can attend to these factors in the parents and really help them feel safe and promote and regulate it and promote the development of our relationship with them. So today, as you see, there's been a real distortion of these processes because the stresses, the inequities, and the lack of resources have been dramatically amplified, certainly in the US, both by COVID and the political unrest, which is quite intense. And so everyone's fear system has been activated, and the clinicians, the parents, everyone, the children, I think Dr. Mulholland's point about, this is going to have a long lasting effect on children because essentially they're living with this level of threat that's, really pretty ongoing. So this is going to have an enormous impact on our capacity to work with families. They're going to be in survival mode. They may be, we've talked a lot about bodies today and about how we've lost contact with families, with children's bodies, with parents' bodies, with nonverbal communication. But also when you're under threat, your body shuts down so you can conserve energy. So you're going to see, in some cases, angry fight. You're going to see retreat and disengagement, or you're going to see freezing and dissociation. And those are some of the phenomena you're going to see in families as they try to cope with this pandemic and with the political situation. And clinicians now can't see the children. They can't see the parents. They've lost that vital connection that is so important. And I just want to note that certainly in the US, the workforce of infant mental health practitioners is unfortunately largely white and privileged and working with a, largely Black and brown population. And it adds, when you actually lose that physical contact at a time of crisis, and I think it was Tessa who pointed out the inequities get even highlighted when you're seeing a family from your own home. And many families in the situation that we're in today resist contact, they disappear, they're overwhelmed, they're hiding out. Their lives may have become, there's so many stories sort of circulating in the United States about parents who, feel so guilty that they haven't kept up their children's schooling because their Wi-Fi doesn't work. They can't possibly access these platforms that have been contrived for their torture. It's really been so hard on parents, and they often have to go to jobs and leave their children in unsafe situations. So their shame potentially is great. So we need to work especially hard to reach out to them. And again, coming from when we're in an unsafe and dysregulated state, because everyone is afraid of getting sick. Everyone is afraid of getting infected. Now, I just want to say with all this dire talk that I was talking to a colleague today, and she pointed out, and she runs a very large intensive home visiting program for psychiatrically ill children and families, I should say. And she was saying that for some families, this has been a relief, that child protection stops checking on them all the time, that they can all actually be together at home, that the parents who are never able to be with their kids during their waking hours are home with them. Fathers are home with them. It has been actually a silver lining for some clinicians as well, who are able to be with their children, even though that poses problems with working. But there have, for some families, been silver linings, and even the families that we see as really stressed and struggling, while it's been difficult, I think there are many families for whom it's been a little bit of a break, which is good. So the pandemic rule for infant mental health clinicians, number one, is the relationship matters. Number two, the relationship matters. Number three, the relationship matters. That is, we are here in the roughest storm. We're here with you, and we're going to stay in contact with you. And really what we have to do is maintain contact in whatever way we can, right? And use the relationship that we've already established to provide as much safety as possible and as much regulation as possible. And we do this despite the absence of personal contact, which gives us a much better sense of where we are. Now, on the one hand, somebody used the word creativity before. This often demands real creativity of the clinician. And sometimes that can just be overwhelming, you know, to think about how am I going to do this? You know, phone, text, telehealth, which often doesn't work. Often with families, you can't even hope to get an internet platform, and so you're forced to use FaceTime, and is that HIPAA compliant? And all these things, you know, just tend to go out the window. But then I've found a number of home visitors to be very creative in using, you know, they go by the house, they're recruiting a new family, and they go by the house and they wave. Or they bring diapers to the door, or food. I mean, there's so much need for concrete resources in a situation like this that I think it's easy to lose sight of how important those things are, and how first we have to provide what's needed. That's key to safety and regulation. And then we can work on the relationship, and then we can work on their inner life, which is the top of the triangle. But if we're not providing those supports, which are so needed by many families right now, we've also, in some country, I mean, in Denmark, where we've worked quite a lot, they were able to do what they called walk and talks, which is they walked 6 feet apart from the parents and child, often a baby in a stroller. But they wore masks, but they were able to observe the baby and the mother and to conduct the session outside. As I mentioned before, you can have a wave by, a drop off, and all of these, and often you make more frequent contact for shorter periods of time. You know, again, this demands enormous flexibility and a willingness sort of on clinicians' parts to do what they hadn't imagined that they would be doing. This may not be your view of what your infant mental health practice is, although I think, you know, for a lot of people it certainly is. But, you know, we drop off diapers, food, we make shelter arrangements, we facilitate access to medical care and social service systems, and we're just sort of reaching out to get them connected to the world. And then I think you have the opportunity to deal with intense, overwhelming feelings, and manage families' sense of terror and rage and loss. And I'll never forget, a colleague made a film after Katrina, and I know I'm running out of time, of a therapist who was working with a patient during Katrina as an adult therapist. And she, of course, the therapist had also been displaced, and she was talking on the phone with the patient. The patient said, "Do you want to know what this is really like?" And she let out a blood-curdling scream that went on and on and on. And the therapist sat there, felt it. Of course, she felt much the same. And that's what we do once they're regulated enough, well, not necessarily regulated, but that they feel safe enough to tell us about this. But we have to do this other work too, which supports the kind of work that we hope to get to. And I know so many colleagues have ended up really doing a level of triage and disposition that they hadn't imagined that they would be doing. And sometimes they're doing it without backup from their supervisors because, you know, they move away, they move to the country, they go away. And oftentimes the line clinicians are left managing very, very tough situations. But if they then can come to the families can then come to the relationship and make use of it to come back to reflection. And I've got these arrows going in a circle here. Actually, I have to say I didn't make this slide myself because I don't know how to get the arrows on there, but that we move when we're working with a family, we move in a circle. We make sure they don't feel threatened. We make sure they're fairly regulated. They're not fleeing us, fighting with us, and that we're stabilizing the relationship, and then we can reflect. And these things, you know, as Ed Tronick taught us, there's a lot of rupture and repair that goes on. And that's the cycle of it, that it's not, we never get to the top and stay there. We're always working our way back to it, away from it, back to it, etc. So thank you very, very much. I appreciate it.
Thank you very much, Arieta. That was very powerful and important, just reinforcing again the basics that we need to think about ourselves and how we're understanding our own experience in the middle of this crisis, how we regulate ourselves and help others to do that so they can be mindful of the baby and other things. So thank you so much again, and we'll have a chance to talk about that in a moment further. But I'd like next to introduce Professor Joy Osofsky from New Orleans. And Joy is a clinical and developmental psychologist. That seems a very modest way of describing Joy's contribution to so many fields of mental health, but clinical and developmental psychologist, Paul Ramsey Chair in Psychiatry, and Leman Professor of Child Welfare at Louisiana State University of Health and Health Sciences Center in New Orleans. She's also Director of the Harris Infant Mental Health Center, past President of WAIMH and 0 to 3, and Honorary President of WAIMH. Dr. Osofsky played a leading role for children and families after Hurricane Katrina, and currently she's co-investigator for the National Child Trauma Stress Network Center, Terrorism and Disaster Coalition, and for child and family resilience. An amazing resource is the National Child Trauma Stress Network. In 2020, she was awarded the Translational Research Award from the International Congress on Infant Studies, and she's been the recipient of many other awards too. And today, Joy is going to talk to us about supporting infants, young children, and families related to COVID-19. Thanks very much, Joy Osofsky.
Thank you. Great, I think we're good. Everybody can see my PowerPoint?
Yep.
I really, there are pluses and minuses to being the last speaker. You can build on what everybody else said and then hope that you have something new to offer. But actually, I believe that actually my presentation will build on a lot of what came before in some new ways. What I was thinking about when I was listening to Arietta Slade, well, first of all, I was thinking about when I was listening to Hisako Watanabe. Oh, okay. When I was thinking of our time together after the earthquake, tsunami, and nuclear disaster, and I was thinking a lot actually in preparing this presentation about what it was like in Fukushima when the parents were so afraid to have their children go outside, and they were afraid as well because of the radiation that we couldn't see. You know, just like COVID-19 that we can't see, you know, and it's been reminding me of that. And Campbell Paul, when we were talking about preparing the presentation, asked if I would also compare it to some extent to other disasters as I go along. I want to mention also related to what Arietta Slade was talking about with relationships, I'll obviously be talking about that as well. Just today, I had an article come out in the journal Psychological Trauma on psychosocial and social impact of COVID-19. And we were starting to think probably 6-8 weeks ago about the inequities with COVID-19, and we decided there was a call for papers that we should publish something in this area, which we did, because we need to be talking about it, we need to be bringing it to people's attention, and this was even before the eruption that we've had in the United States, the eruption of racism in the last little while that Dr. Slade was talking about. And I think it's really helpful for us to think about not the differences between disasters and then also how to support children and families, which I will be doing. But my slides aren't moving. Well, I shared my screen. Okay.
Go to the bottom left for the screen. The image of the screen that, yeah, next one. That's it. Yeah, I think.
Oh, thank you. Okay, I now have control of it and it'll move.
Yep, beauty. Thank you.
Ah, wonderful. Okay. So I want to talk with you about what's most important for young children and families. We heard during all of the presentations about the importance of relationship. We learned from Hisako Watanabe issues of communicative musicality, how very important that is. And we heard from the other speakers about relationships between children, and then Arietta Slade talking about the relationship, and I will be emphasizing the relationship too, because there's no substitute for a secure relationship. That's how children feel safe. One of the things, though, that's very difficult with COVID-19 is being present, being emotionally available. We are all so traumatized in many ways, frightened and anxious ourselves, that we really have to work hard to be present. And I'm going to talk a little bit about that. But it's important to listen to them, to learn what they know, to clarify what they don't know, and even for young children, and help them feel safe and secure. I'm going to be talking about the importance of new routines. Life is very different now, and we need new routines. So this is a cartoon that I clipped a long time ago during 9/11 when the Twin Towers went down. And I think you can see on the bottom, it says, "Daddy, can I stop worrying now?" And you can see a TV screen up there. Because the TV screen, if we watch it too much, or the social media, if we watch it too much, worries parents and worries children. And so the child turns to the father in this cartoon and said, "Can I stop being worried?" And the father needs to say to her, "Yes, you're going to be okay, and I'm going to take care of you, and I'm going to keep you safe." It's really hard for us to say in the world of COVID, but that's what we need to say to help children feel secure under these circumstances. And so, as Campbell had mentioned, I've done a lot of writing and work in the area of trauma, in the world of trauma and the effects of trauma on children. And we all know that trauma affects children in all these different ways. And all of these factors now are extremely important in the world of COVID. So we talk about biology and physiology and brain development. You know, what's it like for young children now to be so isolated and to be separated from caregivers that read to them and talk to them and help with that brain development? Relationships and attachment. Very many of my colleagues, I have a number of colleagues who have young children in the first 6 to 8 months of life now, and they're really worried about the attachment relationships of their babies because they're not exposed to the world in a usual way. I'll be talking more about behavior and emotion regulation and how this also may be impacting on cognitive skills and as well as social and emotional development. So how does COVID-19 differ from other diseases? And I think what I'm talking about will have a lot of relevance for international work. I know there was some focus on work in various countries, but this seems to me, from everything I've read and know about, and then also, as Campbell Paul knows very well, and Hisako as well, I have a son and daughter-in-law and 2 grandchildren who live in Hong Kong. They were in the United States for Chinese New Year in January and stayed here a couple weeks longer because of fears of COVID in Hong Kong. They decided to go back, which was actually a good decision because, as many of you may know, New Orleans, although we have a smaller population, has been a hotspot for COVID percentage-wise, similar to some of the larger cities. But they went back with their 5-year-old and 3-year-old children with masks on. My daughter-in-law is Chinese, and wearing masks is very common within Asian culture. But they went back with a huge amount of uncertainty. That's what COVID brings to all of us, and that's what differs from other disasters. The uncertainty, duration, when will it end or be controlled? I was in Oklahoma in October for 3 days doing presentations on disasters, both natural and technological disasters. And one of my colleagues there said in Oklahoma, they have many more tornadoes. Where I live in the Gulf South, we worry about hurricanes more, although we do have some tornadoes too. And they said they preferred tornadoes, even though I find it very frightening, because they said that they can know when it's coming and then it's gone. Whereas with a hurricane, it lasts a much longer time. The extent of destruction, depending on the size of the hurricane, can be very great. And that's one of the issues about uncertainty, about duration. When will it end or be controlled? With a tornado, it goes through. With an earthquake, it happens, and then there are aftershocks, but it does end. Although, as Hisako and I were experiencing together, when you have a tsunami and a nuclear disaster, that also brings some of this uncertainty as well. Also with COVID, anxiety and worry. Am I going to get COVID? Is my family going to get COVID? Are my grandparents going to get COVID? I did in late February an interview with NPR, National Public Radio, where they did they're very creative writers, put together a cartoon. They interviewed some of us who do work in this area, put together a cartoon of how to talk to children about COVID-19, how to talk about the coronavirus. But one of the issues that comes up is worrying about grandparents. Am I ever going to see them again? Are they going to die? You know, we certainly have death with disasters. I can tell you, we had a lot of deaths with Hurricane Katrina, and I worked a lot on the mental health recovery for children and families. I was the coordinator for the state related to Louisiana Spirit. We've had many more deaths in Louisiana from COVID than we had from Hurricane Katrina. And then the issue of social distancing. That's just the opposite of what we do with other disasters. With other disasters, we're out there helping people. One of the things that I talk about, I know I'm a mental health professional, not only a clinical and developmental psychologist, but a psychoanalyst, and I hung out. We hung out among first responders. We hung out among people who were impacted. You know, that's the way you help people with a disaster, is being with them. Well, with social distancing, it's just the opposite. And I emphasize it should be called physical distancing and emotional connectedness, because social and emotional connectedness is crucial with COVID. It's crucial to support people. Physical distancing is crucial to protect people. And so children and families don't get support from the usual people, extended families and friends. You have to figure that out. Arietta Slade was talking about the virtual treatment that we provide. It's different, you know. And then there is broad economic impact with disasters, but COVID's impact is worse than any other disaster. It's just so broad, the economic impact on communities and individuals. And then the issue of fear, something we can't see and can't control. So certainly there's fear with regular disasters, but we understand what's going to happen and what the course is going to be. Even if it's bad, we understand better. But COVID brings all of that increased fear and uncertainty. Okay, so schools and childcare centers are closed if there's a major disaster. Our schools, many of our schools in the New Orleans and surrounding areas were impacted by and destroyed by Hurricane Katrina, and childcare centers were closed. And we set up a childcare center on the boats that were in the harbor to house first responders, 80% of whom had lost their homes. But not all schools were closed, and people could go to other areas and get into schools. And then childcare centers could be opened in other areas. There wasn't any issue about being around people. The other thing, when I mentioned earlier about the cognitive impact of COVID, I've heard from very many people about their children just aren't able to learn virtually. And if you think of parents having children at home, trying to work, they have children at home, or having to go to work and somehow figure out how to have education for their children, it's just not working very well. For more privileged people, it tends to work better. But children, I've heard and read many things about children being impacted by cognitively, not being able to have the opportunity to learn for a long period of time, many months. And then I mentioned before the direct contact that's so important for recovery and resilience. That's really a main thing that those of us who do disaster response do, is out there and do direct contact. And then routines. Young children need routines. We need routines too. I wonder how many of you sometimes wake up, those of you who've been on lockdown, and not sure what day it is. You know, we need routines, and children need them. Young children and families very much need routines. And so some families are concerned, as I mentioned, about disruption of attachment relationships and concerned about how this is going to impact on development. And then there's much more pressure on families with isolation. You know, for those who are even doctors working in the hospital, and I know many people who are listening in are healthcare providers working in the hospital, they have to be separated from children also, and the children may not understand what's going on under those circumstances. So that's another difference that we see. We've alluded already to an increase in domestic violence and child abuse. Figures just came out related in the United States on child abuse, and the child abuse reporting is way down. Doesn't mean child abuse is down, it means those protectors of children, childcare centers and teachers and preschool teachers and neighbors, you know, a lot of them are reporters. So we know the incidence of child abuse goes up after disasters. It's just we can't keep good figures on it. And also there's an increase in domestic violence. Coming out of Wuhan after lockdown, there was a very high incidence of divorce in those circumstances, but also with people being under lockdown and not being able to move away, there's no protection for, usually it's women who are impacted by domestic violence. There's nowhere they can go. They can't get away. We also know there's an increase in use of alcohol and drugs. So again, we need physical distancing to protect people from COVID-19, but we need social and emotional bonds to provide support to people. So these are expectable reactions that we see in young children with stress and trauma in general, and certainly see it under current circumstances. And this dysregulation, emotional and behavior dysregulation, really, as I say, mimics the chaos of the environment. You know, people are very uncertain, people are anxious, people are fearful. And so children will cry more often, have difficulty falling asleep and staying asleep, and nightmares. And I would guess, we have adults listening here, that many of you are having trouble with sleep and having nightmares. It's just something that's happening now with all of the fear and unknown that's going on. For children, we see regression in behaviors. We saw it after Hurricane Katrina. We see it after other traumas. They have difficulty separating, they're clinging, fearful of being alone themselves. And then someone had asked about play with COVID. And it's hard to characterize the play, but one of the things that we often see, that we see with disasters, is repetitive play. When we set up these childcare centers on the boat, we felt that it would be these big boats that were housing families who had lost their homes after Katrina, we felt it would be very supportive to have childcare centers for the young children. And when we set up the childcare centers, and we had no trouble having toys because people send lots of toys after disasters, the first thing the children did was pick up whichever toy it was, whether it was a block or a Lego or anything, and started to play Hurricane. It was very traumatizing for their parents to see them playing Hurricane over and over again, but it's hard to know what children are playing with now, and hopefully they're playing, because that will be something that's very, very important. And then with this dysregulation, for some children, they withdraw, and others, we see a great deal of anger and aggression. What's going to help? And I think it's really important for us to talk, all of us who work in the area of infant mental health, clinicians, developmentalists, whatever, is talking about what helps. So with schools closed, preschools and child care centers closed, and now in the United States, and I think in some other countries, some child care centers are opening, but parents are also afraid to take their children to the child care centers. They have to work, but they're afraid under those circumstances. So there's this kind of ambivalent fear that's coming up again. Many financial pressures on families. So predictable schedules is what's going to help. We have a new normal. When I was actually in Israel last year, I talked with them about a new normal, and we were in Gaza, and it was not a time when bombings was occurring. But when I talked about a new normal, a number of the people came up to me and said, you know, we really can't have a new normal because we would need a new normal every day during that time. But we do need new routines, and we have a new normal now. So we talk to parents of young children and others about setting a schedule, and if the children are old enough, or even if they're young, make it a game and help them set the schedule. We start with meal times and bedtime. You're going to have to add schoolwork. At least that's what has had to be part of it for the last number of months. And then we talk to them about including play. We know play is so important for children. And under these circumstances, people don't think about playing. You know, that it's hard to think about playing, but it's very, very important for children. Also with the schedule, we urge people to remember to be flexible. You know, things may not go exactly the way you've planned it. Something else may be happening. Someone may get sick, a friend may get sick, so we have to be flexible. And then trying to be emotionally available. And maybe if the parent can do it, add a playtime with you. That's so important for children. And then the other thing that we talk about is limiting exposure to media. We need to limit our exposure to media. We have to check the news. It's good to know what's going on, so we should check it once in the morning and once in the evening. But if we constantly are looking at media reports about what's going on and they pop up on our screens all the time, we feel the tension and children will feel the tension. So that's a very important part of the routine. So what can we do? First of all, listening, trying to be there emotionally available and listen. There's a lot of information out there now translated into many different languages to explain coronavirus to children of different ages. They need to know what it is, but they need to know in a way they can understand, and also, again, be told that you will keep them safe. They'll be safe. We need to explain to them why they can't go to preschool or school or childcare. I can tell you from my experience with my family in Hong Kong, they're very strict with their rules. There's a lot of contact tracing. People in quarantine wear special bracelets in quarantine. But they had a little bit of right now they have it very well under control, but they had a little bit of a rise in cases and said no more than 4 people could be together. And so my son had to explain to his daughter, who's 5 years old, why she couldn't play with her 2 friends, because it was a point where they could go out and play. But if she went out, and if her brother went out with her, and then there was a parent, and there was another child and another parent, that was 5 people. And so had to explain. It's very hard to explain to a child, a 5-year-old, why you can't play with your friends. But then parents need to figure out other things that they can do. You know, maybe they can figure out, well, they can figure out how 3 people can be together. And then also, it's very important to talk to children about positive things they can do to be in control. We don't sometimes feel very much in control, but we know washing hands helps. And actually, I was very happy that they controlled things enough in Hong Kong that the school opened and my 5-year-old granddaughter could go to school. And she told me, she talked to me about it. First of all, how she felt about it, but then, and she was happy to be able to go to school. A little nervous and a little scared, but after the first day it was much better. But she showed me the virtual hugs that they learned to do and the elbow bumps. And that's what's going to happen now with schools. So schools are opening. You can't hug your teacher. You do virtual hugs and you do elbow bumps. But then you can feel in control that you can do something. And then, very, very important to make positive connections with family. We can't see them. We can't visit them. You know, now with things opening up in the States and other areas, you can visit people at a distance. But there are other ways to make connections. There are telephones. You know, we're so used to other things that we don't use telephones that much. For those who can have media, there's media to connect as well. But there are a lot of different ways that one can connect. I'm going to end my presentation to talk about self-care. Nobody so far has talked that much about self-care, and it's so crucial at this time for parents and caregivers and all of us. And we talk about self-care, and my guess is that most of us presenting on this in this program, and maybe many people listening, are not doing self-care, which is really important. We need to be able to renew ourselves so that we can help other people. In this country, we talk about Mr. Rogers, Fred Rogers. To be a helper, you need to help yourself too. He talked about the helpers and how important they are, and they're very important now. So we need to take care of ourselves and not be guilty about it. It's so important. Just some of the risk factors for all of us: fear and worry about our own health and that of others. For economically disenfranchised people that Arietta Slade was talking about, it's very, very difficult. There are so many health inequities. If we notice change in sleep or eating patterns, difficulty sleeping again or concentrating, chronic health problems getting worse, increased use of alcohol or tobacco, other types of things. Very important for self-care. So you say, what can I do? I feel overwhelmed. So there are lots of things you can do. I already mentioned, take breaks from the news. Try to remember activities you used to enjoy. We talk about trying to go out for a walk safely, like getting outside and getting some air. Connecting with others is crucial. I was really looking forward to this webinar to connect with people who I haven't talked to in a while or seen in a while. And that seems to really be helpful, even our professional connections for those of us. And also don't hesitate to ask for help, despite all the disruption that's going on. It's very, very important to know there is help there. Interestingly enough, a number of us, we've set up warm lines and support lines, and people don't call them that much. That's another thing that's different from other disasters. When you're out there with disasters, people do talk to you. They know you're there. And if they, they may not talk to you the first time, but the second time they see you, they might talk to you. So that's one of the things, though, that there is help available if people need it. And we've done some lot of resources we help and Instagram types of things. So I just included one of them related to common ways young children react and what you can do to help them. And I also decided to include some resources for parents and caregivers. There are many of them. These are some that we've developed, and then also resources for self-care, some of the websites and other things, because every time I've talked or presented, people would say they're very appreciative when we do something related to self-care. So I really thank you for the opportunity, Campbell. I was very delighted to be asked to join the symposium and be with my other WAIMH colleagues and join with all of you from across the world, because it's very important for all of us to connect and share with others all the time, but particularly at this very difficult time. Thank you so much.
Thank you so much, Joy. That was a wonderful talk, and the last point you made about self-care is so important, so powerful, and certainly that was what we was hoping would come in part from the webinar series, that people would be able to make some connection with professionals who we otherwise would have been meeting in person, say in Brisbane, but for us to use the virtual connection media that are there as we're expecting families to do and other professionals. So thank you so much for really highlighting that as a common thing with trauma and catastrophes, but some of the special ways that this has impacted on social relatedness and the need to keep that in our mind. I'm just going to put on, with a bit of luck, my last slide, a couple of slides, and just to thank each of the presenters. We've had a really rich and powerful set of presentations today. And I guess I'd just like to emphasize that but people have capacity for response to crises with creativity. We can have creativity, humanity, and this positive change, but it needs leadership. And I guess that's part of our job as professionals, is to help families, but also help ourselves and our colleagues. Just to come back to Colin Trevathan, he talks about the human neonate having neurobiological preparedness to participate and share meanings with others with this coherent, rhythmic, purposeful consciousness. Babies are born with motives and emotions for action that sustain human sustainability. So our task is to do that with ourselves and our colleagues, and to facilitate circumstances for the baby and the parent to get to know each other from the beginning in even these scary and frightening circumstances. So I'd like to thank you all for presenting. The presentations will be available through the WAIM website, and hopefully we'll see as many people who feel and are able to travel with us again in Brisbane at the end of June next year. And there'll be some virtual vehicles for doing that, but we hope it'll be as much person to person as can be. And as I said before, if you're looking for actual social distancing, you can't come to a better place than Queensland. Whereas if you get out of the city, you can be thousands of kilometres from the next person and be part of the world, part of the environment that our traditional owners have looked after for so long. I think you'll enjoy that aspect very much. So again, thank you very much to everyone, and I hope to keep in touch, and we're going to have some more of these webinars over the following months leading up to the Congress next year as well. So again, thanks to everyone, to Joy, to Tessa, to Kim, to Arieta and Hisako, and thanks to Astrid for helping us get it all off the ground, and most importantly, thanks to Gus Fraser, who's been there behind the screens, getting us all together. So thank you very much, and I hope you have a good evening, good sleep, or a good productive day, and have a good rest. Bye-bye. Thank you so much.
Yes.
Thank you very much.
Thank you so much.
Bye-bye.
Campbell, thank
Bye.
you.
Yeah.
See you later.
Thank you so much.
Bye-bye.
Bye-bye.
Bye.
Bye, thank you.